Hey guys, welcome back to the East Tennessee Health Forum. This is our second event of 2024. Our first one back in January was a huge success. Had some wonderful speakers, wonderful collaboration and encouragement that came from that night. And the main vision of the East Tennessee Health Forum is to bring like-minded medical community together, practitioners, administration, nurses, techs, anyone in the healthcare field that has the desire to learn and has a desire to have community and has a desire to roll up our sleeves together and hopefully impact the health of our community long term. And so tonight the topic is mental health. We have an encouraging speaker. We have a guest psychiatrist from New Jersey speaking with us tonight. And then we're going to have a panel of some local healers in our area in the fields of addiction and neurofeedback and a psychiatric nurse practitioner. So stay tuned and enjoy the night. And Dr. Hedaya he's a psychiatrist up in New Jersey. Really quite brilliant man. He's been practicing integrative psychiatry since the 80s. He teaches with the Walsh Institute. He teaches with the IFM, Institute of Functional Medicine. And he has several really good books I've started reading. The Biological Psychology and the Antidepressant Survival Guide, helping patients learn how to mitigate side effects while getting the benefits. So I'm just going to play Dr. Hedaya's video while we're eating. Please feel free to keep chatting and meeting your neighbors. So Dr. Hedaya, thanks for joining us.
My pleasure.
What was it that drew you into a functional medicine approach or more of a root cause approach early on in your career?
Two things. One is doing the highest quality at whatever I do. It's just my nature. And then the second thing was trying to understand and not just memorize, but understand things. So I was in practice for a couple of years, had a woman with panic disorder who really wasn't getting better. I've told this story so many times. And, I tried everything that was available at the time, CBT and group therapy and all the meds that were available, and nothing was working. My hypothesis was she was having panic because she was in a bad marriage. A year in, she paged me with a panic attack on Saturday night. I went into the office Monday morning thinking, something is going on here because she should be better by now. I had one piece of data, I had a CBC. And the only thing that was abnormal was the MCV, the size of the red blood cells was 101, but the range was 80 to 100. And I had ignored it because, you're trained in a hospital setting, you treat train wrecks, you don't treat the subtleties. And it could be B12 deficiency, worked her up, Schilling's test. She comes back abnormal, give her B12 injection. And with her first injection, her panic is gone.
Mm-hmm.
Like, oh my God, what else am I missing in my patients?
What do you think are some of the causes that's led to our country's historic rise in anxiety and depression? We'll just focus on those two. What do you think's contributing to those things?
I do think that the biggest thing is very broad. And by broad, I mean cultural failure. And I mean environmental failure, because we're swimming in toxic chemicals, thousands of endocrine disrupting chemicals, toxic chemicals. If I had to say one thing, I would probably say the breakdown of the family and the larger community. I'm not even going to talk about the whole country. I'm just going to say people are not really embedded in a community. They don't even know what community means anymore.
And so in your practice, if we focus in on depression and anxiety, because it's such an overwhelming number of people, are there some common threads you tend to see, maybe where lab work is helpful, where medications or supplements can be helpful? What are some, if someone comes in with depression or anxiety, where does your mind migrate first?
I would give you this analogy, broadly. I'd say, we have hardware, we have software, and we have the cloud, right? Hardware is your body, right? What's going on in the body? The software is your thinking patterns, your values, your way of looking at yourself in the world, right? That's your software. And then you have your cloud, which is the spiritual, okay? You can't really, it's hard to repair the cloud, the spiritual connection, until you have the hardware and software working. I mean, you could work on it, of course. If you've worked on the cloud before and then you get ill, you actually have protection. But most people that come in know the hardware is a problem. So you want to take a very careful history and look at the various systems, digestion, nutrition, immune function, infection, inflammation, detox, oxidative stress, hormones. All the hormonal systems are known to affect the brain. Structural problems, chronic pain, sleep problems, lifestyle problems, etc. You want to survey all of that and see where do you think the problems are, the main problem. But remember that if you can work on those pillars, sleep, diet, movement, spirituality, right? Movement I mentioned. So if you can work on those, many things improve. Many things improve.
Mm-hmm.
You do, your screening blood work. If I had to say what would I do, I always look at the adrenals and the thyroid. I look at 8 a.m. ACTH and cortisol. I'll often do either a salivary or urinary cortisol through the day, so I get a better picture really. And then thyroid, always looking at thyroid function because it plays a big role. And look at the homocysteine. In order to assess B12 and folate, I always look at the CBC, iron indices, and I'll look at the homocysteine. Then and then you look at how those relate to each other in a dynamic way, because you can mask a B12 deficiency with low iron, right? So you really want to need the iron to factor that in. And then I will look at insulin, and then I will let's see. I probably look at inflammatory markers. If there's symptoms of inflammation, I'll do CRP, SED rate, C4A, TGF-beta 1, maybe a couple of others, depending on what I see, autoimmunity or something like that.
How much more do you think you have enjoyed psychiatry practicing this way versus the way you were trained?
There's no comparison.
No.
Listen, when I first went into psychiatry, I would wake up every morning thinking, how blessed am I to be able to do this? But after about 2 years, I was like, okay, he's one of those, she's one of those, I'm one of those. Everything's classified, everything's the same. And I was like, oh my God, I got to do this for another 40 years. Oh my God. And then I called my mentor from Georgetown. I said, Frank, I don't know what to do. It was Frank Calabat was his name, great guy. He says, if you don't keep learning, you're going to be in trouble. And I was like, oh, that's the key. I got to keep. Let me tell you one other thing. I learned in 2017 that I started doing quantitative EEG. We actually look inside the brain with a good amount of detail that correlates with functional MRI and diffusion tensor imaging, et cetera. It's well established. We can see the different nerve tracts in the brain. We can see the different Brodmann areas. How are they functioning? Are they unstable, excessively stable, etc. Tremendous amount of data. I treated a woman who had early dementia and facial blindness, and I was blown away. After I was ready to do the QEEG, the quantitative EEG, which is artificial intelligence, basically analysis through artificial intelligence of the EEG. It's not a visual inspection of the record, it's an artificial intelligence. It picks up things you can't even imagine, and it was developed with a database from the National Institute of Mental Health, et cetera. So it was a solid tool. You do it in the office or in the person's home. And her brain was not normal. And I was very disturbed because she felt a lot better. She still had symptoms. So what we did a combination of hyperbaric oxygen. We did laser transcranial biomodulation to her brain. Anyway, treated her. Her hippocampus normalized. It was about 2.5 standard deviations from the norm, and it normalized over 30 treatments. I published this. And her facial blindness, which she had for 7 years, cleared up after the first laser treatment.
Wow.
So we now have tools. You could call it part of functional medicine. I don't care what you call it. But we now have tools to look inside the brain and really see what's going on inside the brain. And we've been able to actually, with 75% reversal of aphasia, visual problems, people have visual snow,
So some of those more cutting edge technologies, where would people go to learn that? conferences, books, both?
Yeah, I mean, that's what I did. I studied QEEG. Went to conferences on HBOT and learned about lasers, and I did it. I'm just not. I would train people, but I would need a group of people to train. And I get one or two people here or there, but my time is so precious that I can only do it if I have a group of people to train. Then I'd be happy.
So at our talk tonight, we have a lot of people in the field of psychiatry. There's med students, there's residents. What might you encourage them with on their journey since they're just starting off in the field of psychiatry?
Just starting off, follow what my mentor Frank Calvert said. Keep learning, keep an open mind. We don't know everything. Most of what is out there, we don't know. We like to think we know a lot, but we don't. And psychopharm and psychotherapy are great. Don't throw them out, but they are not the be all and end all, and they're not going to do the job for most people. We know that statistically that for mood disorders, anxiety disorders, they are useful tools, and but you really want to address the whole picture. That's again why I call it whole psychiatry.
Mark Hyman's favorite question. We'll end on this one. If you could be king for a day and someone put you in charge of psychiatry for the USA, what are some things you would do?
You know what? He interviewed me when I ran rounds at the Cleveland Clinic, and he didn't ask me that. So I think I would support the family. I would really strengthen the communities and the family. Only thing is it has to be life affirming. That's the main thing.
Yeah. Enjoy hearing from you. Thank you for those encouraging words.
Yeah, and after Dr. Carroll speaks with us tonight, make sure to go chat with all of our sponsors. They're wonderful people who really care about helping our community heal, and that's why they're invited. So thank you, guys. So our main speaker tonight, Dr. Traci Carroll, who I've just gotten to meet recently via Seth, so thank you guys for that. She is just a wonderful person to have in our community. Graduated from Northwestern University with a bachelor's of music. I believe it was clarinet. Yep. And then she went on to get a PhD in English, and she worked for a little while. Was that when the yoga studio came? Yoga. Yeah. Massage, yoga, all sorts of ways of helping people heal. And she decided, I'm going to go back to med school. And so went to Quillen in 2010, graduated in 2010, and then completed her psychiatry residency. And now she runs the Wellness and Wholeness Division for the VA and is serving our patients at the VA system. And so I asked Traci to talk with us on what are some cutting edge treatments coming out in the field of psychiatry. There's ketamine things coming out, there's psychedelics coming out. And so I just said, Traci, you got the runway, and I would just love to hear what you see coming down the pipe. And so there'll be time for questions after, but with no further ado, Dr. Carroll.
I appreciate the introduction. It's great to see old friends and new here tonight, so thank you for the opportunity to come to really reflect on past and future of integrative psychiatry. And one of the main thing I want to talk about tonight is psychedelic medicine. Whether we're ready for it or not, it's coming. MDMA is expected to have FDA approval by the end of this year. Psilocybin will likely follow in 2025. So this is going to create a big shift in the way we treat mental health conditions. And even if you don't anticipate using psychedelics in your practice, I guarantee that you'll have patients and clients asking about it, maybe people who are using psychedelics in someone else's practice, and you might be in a position to help someone who is undergoing an uncomfortable internal shift as a result of using these agents. Okay, so how did we get here? If we look at the past 80 years of biological psychiatry, it's been dominated by the monoamine hypothesis, which postulated that anxiety and depression are largely serotonin deficient states. And as you can see from this timeline, the monoamines dopamine and serotonin have dominated research up until the last couple of decades. Then in 2022, this publication came out which was considered a watershed moment in thinking about depression. It's a systematic review that shows no support for the hypothesis that depression is caused by lowered serotonin activity or concentrations. So those of us in clinical practice could have told you that there are limitations to SSRIs, SNRIs, and researchers started looking more closely into the role of inflammation and into other neurotransmitter systems like the glutamate system. When we start to talk about the history of psychedelic medicine, it's a little complicated. We can't really talk about it without talking about indigenous cultures. This is a picture of Maria Sabina, who was a Mexican healer in Oaxaca region of Mexico. She led sacred ceremonies in her community called the Velada, which used psychedelic mushrooms, psilocybin mushrooms, to help, for example, to help find people who were lost in the jungle, solve problems that otherwise the community could not solve. In 1955, R. Gordon Wasson, who's pictured in the lower right, he was an ethnomycologist, and he was sent by the CIA as part of the MK Ultra project to infiltrate this community, infiltrate these sacred ceremonies, and find out something about psilocybin, which he did. He brought spores and information back to the United States, and before this interaction between these two cultures, there is no mention in the medical literature of any medicinal property for psilocybin. So we literally do not have psychedelic medicine without these indigenous traditions. The timeline is long and complicated. I'll just hit a few high points. In 1939, LSD was synthesized, and in 1943, Albert Hofmann accidentally discovered that it had psychotropic properties. And by 1953, Sandoz Laboratories was actually mailing LSD out to psychiatrists and therapists so that they could experience what some of their patients with schizophrenia were suffering with. There was a huge wave of psychedelic research between 1950 and 1970. This is Bill W. in the upper right, the founder of Alcoholics Anonymous. Lots of research on LSD and alcohol use disorder. Very promising research. It is particularly useful because the psychedelics do not trigger dopamine release through the reward pathway, so they're non-addictive. All this came crashing to a halt in 1970 when Richard Nixon passed the Controlled Substances Act, which made all of the psychedelics and marijuana Schedule I drugs, and they were illegal. So we did not have any continuing research until 1986 when Rick Doblin, who's the fellow here on the lower right, founded the Multidisciplinary Association for Psychedelic Studies, and the rest is history. And as I said, MDMA will likely be used in clinical practice by the end of this year. Okay, this slide, there are a lot of words here that you don't necessarily need to know. It's a slide about the neurotransmitter systems and receptor systems involved in psychedelic substances. Bottom line, serotonin 2A receptor is responsible for most of the effects of psychedelics. We know this because ketanserin, which is a serotonin 2A antagonist, blocks the effect of most of the psychedelics. And even though some of them, as you can see, are very complicated, especially ayahuasca affects a number of receptor sites, the final common pathway is a window of increased neuroplasticity and a kind of entropic brain connectivity. So we usually have these stable hubs of connectivity, but everything just sort of dissolves and reconnects. We have that hyperconnectivity, and we have a huge output of brain-derived neurotrophic factor in the brain. Both of these conditions create a huge increase in the capacity for social learning. In the periphery, outside of the central nervous system, a lot of the psychedelics block TNF-alpha mediated inflammation. This is really exciting for chronic pain and inflammatory conditions that have been otherwise difficult to treat. So this is just some of the targets for psychedelic therapy. I'm especially excited about obsessive compulsive disorder and eating disorders because we don't really have good medical treatments for those. So I'm hopeful that we'll have some openings for people who are suffering tremendously. Okay, this slide contains a little joke. It's about the double-edged sword of the neocortex. Okay, I'm a fan, but there are drawbacks. So basically, this describes two different modes of function for the brain. On the left side is our everyday, normal, waking consciousness. Okay, it is, in that situation, the neocortex, the activity in the cortex is directed by the default mode network, which is like these stable, limited hubs of connectivity. The default mode network allows us to look out to the world and experience it as a coherent whole. Okay, so we experience ourselves as discrete individuals with a past, present, and future, going through linear time, interacting with the objective world in a more or less predictable fashion. Okay? On the other form of function is non-ordinary states of consciousness. And there are a variety that I'll talk a little bit about. In that situation, the default mode network is suppressed. Its functioning is dampened. And so that allows these more intuitive modes of perception to come to the surface. So the problem with the default, like, why would we want to do that? Why would we want to let go of, coherence? The problem is the default mode network allows us to get stuff done, but it also creates an immense amount of suffering. So if you've ever worked with people who have problems with negative ruminations, negative self-talk, addictive patterns, compulsions, rigid thinking, obsessions, this is the default mode network doing its job too well. Okay, and it's also responsible for the sense we have, especially today with all of our social media, of being inundated with information. All right, it's a painful experience sometimes. So the indigenous societies and some of these ancient spiritual traditions kind of knew this. Okay, and so they had devotional and ritual practices for going from the left side to the right side, okay, for accessing this other mode of function. And some of the traditions call it crossing the torrent. This idea that we're just inundated with this torrent of information. There are many drivers of these non-ordinary states of consciousness. They're usually repetitive, monotonous, somatic drivers like breathing, dancing, chanting, repetitive prayer, drumming. So these repetitive patterns facilitate that shift from the default mode network over into that more intuitive hypofrontality state. So, I doubt that you're going to hallucinate while you're fly fishing. I don't know, maybe it's possible. But so these are kind of recognizable activities that we can kind of get a taste of that dormant capacity when we go into a flow state. When we do any kind of activity that it just takes us into a zone, and we're in contact with a different part of ourselves. That's like a kind of a precursor to a more dramatic shift into a non-ordinary state of consciousness. Okay, so I do want to give an historical example, just so this is not super abstract. This is a picture of Kali. This is from the tradition of Tantra. Kali's name comes from the Sanskrit word kala, which means time. And mantra literally means tool of the mind. One of the main features of non-ordinary states is the experience of an altered sense of time, specifically an altered sense of our notion of autobiographical time, what's sometimes called the narrative self. You know, these stories that we tell ourselves about who we are, and they may or may not be correct, and they may or may not be helpful. Just to look at some of the imagery here, Kali's sword is a tool to cut off the head of the ego. She's there to like cut us away from these false stories about ourselves that no longer serve us, to cut us away from illusions, delusions, so that we can get to the truth of ourselves. She's got 50 severed human heads in a necklace around, in a garland around her neck that represent the 50 letters of the Sanskrit alphabet or mantra. So what's interesting is research that's been done on mantra. fMRI shows a shared neural signature with all the other non-ordinary states of consciousness, and guess what? It's reduced activity in the default mode network. This is experienced as a dissolution of the self. So most of the research that's been done on these non-ordinary states of consciousness has been done on shamanistic and meditative trance states, hypnosis, placebo effect, and psychedelics. And they all, there's a common denominator. They all describe similar experiences, similar phenomena, like dissociation, a total absorption in the moment, a unitive experience of being one with the universe, increased feeling of spiritual meaningfulness or openness to new ideas, a change in perception of time and space, and a change in your habitual way of seeing yourself, increased reflection and introspection and positive mood. So these are all across the board. These are the things that happen when people shift into a non-ordinary state of consciousness. And it is, these self-reports find consistent correlations on PET scans that show altered blood flow and glucose uptake in those regions of the brain responsible for maintaining the default mode network. So this is the claustrum. This little wedge, it's responsible for the shift, the cross from ordinary to non-ordinary state. Okay, so it's this little irregular sheet of glutamatergic neurons. It's like kind of stuck up under the bottom of the cortex, and it separates the cortex from the basal ganglia. And as you can see, it is uniquely positioned to send projections throughout the whole brain, anteriorly and posteriorly. It can go, you know, it goes everywhere. So it is responsible for maintaining the activity in default mode network. Like it keeps those hubs stable. Okay, under the influence, and it has the highest concentration of serotonin 2A receptors anywhere in the brain. So we take psychedelics, they go to the claustrum, and instead of like depolarizing, it causes this recurrent release of glutamate, like stimulation, stimulation, stimulation through the entire brain. Okay, it causes the default mode network, those stable hubs, to sort of dissolve, and then you have this period where there's hyperconnectivity. All these different regions of the brain that are normally cut off from each other are connected. This manifests as changes in perception, cognition, and behavior associated with the psychedelics. And this is kind of a before and after picture. On the left, you see the ordinary arrangement in the brain where you've got these kind of, there's not a lot going on, right? There are predictable connections, predictable hubs that are talking to each other to maintain our sense of coherent, predictable reality. Okay, game over once psychedelics are on board. Everything is connecting with everything, and so at this point you've crossed the torrent. Okay, it's a state of entropy where we can't quite predict what kind of perception is going to pop up. And new modes of connectivity are possible for a period of time. Neuroscientists who work on mathematical models of neural data use this image, this model of the attractor basin, to talk about how the tendency of neurons that wire together to fire together. Okay, so this explains, it almost feels like a gravitational pull in our mind of these recursive loops of thought, you know, self-judgment, self-blame, self-criticism, criticism of other people, complaining, all these negative maladaptive habits, addictions, we've seen it, right? We've seen it in ourselves, we see it in our people, in our family, patients, everybody we work with every day. So it's almost like it's an attractor state. It's like a gravitational pull. This is another way of saying neurons that wire together, fire together. So under the influence of psychedelics, the gravitational pull, the attractive pull of those thought basins starts to relax, okay, starts to weaken. And so if you think of the brain as like a landscape, instead of having these deep funnels, these deep divots, it all starts to flatten out. Okay? So that little ball, if you think of the ball as your thought, attention, awareness, curiosity, it might take alternative pathways through the system rather than being immediately sucked into that negative pattern. And so this allows us to integrate an arising memory, thought, or emotion in a new way. We might be able to step back and get a different perspective on it. Entropy in the brain increases the probability that emotional memories that are usually inaccessible because of ego guarding, you know, defenses that we've built over years, increases the probability that that material could emerge and come to the surface. So when a previously consolidated memory, especially a traumatic memory, is reactivated, it can be experienced in the presence of a skilled therapist. It can be experienced somatically. It can be perceived from a different perspective, and then it can be reconsolidated in a different way so that it starts to lose that negative, threatening emotional charge. This is a really different model for thinking about using medicine to treat mental illness, okay? So rather than taking your daily dose of, you know, sertraline or, you know, whatever, the medicine is seen as a potentiator for psychotherapy. It puts the brain in a receptive state so that productive therapy can take place. Rather than dosing every day, people might dose every 6 months. There's less emphasis on relieving specific symptoms as delineated in the DSM-5, and more attention to helping the person stay in this more adaptive state of consciousness that is naturally going to lead to symptom resolution. This is absolutely in line with cognitive behavioral therapy. It's absolutely in line with mindfulness approaches that help people increase self-acceptance, self-compassion, present moment awareness, and psychological flexibility in the service of achieving core life values. So this is not a replacement theory, like the idea of replacing a deficient neurotransmitter. Okay, in this system, the perturbation of that brain connectivity is seen as a golden opportunity to observe maladaptive patterns and to begin to restructure them in a more adaptive way. Another image from systems theory that's really helpful is the strange loop. And this basically is describing the tendency for the self to drift back and forth between being an observing subject and then being the object of attention during a heightened state of consciousness. So under the influence of psychedelics, who we are is no longer a fixed, stable entity from which to objectively see the world. I'll say that again. Who we are is no longer regarded as a fixed, stable entity from which to objectively view the world, but an inherently changeable process. This is a lot to wrap our heads around, so I'm going to talk a little bit more about it. So this is one of those research reviews of various non-ordinary states of consciousness. So the whole dissolving the self thing wouldn't be a big deal, except that in our current cultural framework, we don't have much of a way to support people who are undergoing this experience that can be very challenging, frightening, and destabilizing. In the context of an indigenous ritual, like Maria Sabina's Veladas, or in the context of a guru-disciple relationship, if somebody is chanting mantra, ego dissolution is embedded in a well-established tradition with generations of experience, clear intentions, and a well-defined framework of cultural support. So the person crossing the torrent, going from one side of the sword to the other, is held during that period of dissolution and then welcomed back with meaningful ritual and ceremony to reaffirm their personhood and to welcome them back into a place in the community. So we just, by and large, we do not have this. This is not part of our culture. So in the absence of those cultural frameworks, we have to devote meticulous and sustained attention to set and setting and to therapeutic technique. Super important. Even if we don't live in that culture, that has those kind of ritualistic or teacher-student relationships in place, we need to start finding some way of approximating it, or reconnecting with those old traditions, or maybe reinventing a new way of providing cultural safety and support in order to help our patients. Michael, I promised you the medicine wheel. Here it is. So this is the Lakota medicine wheel, and it's just one example. I'm going to, in a couple of minutes, I'm going to go through just some quick visual images of ways of conceiving of reality. They're a little bit different from ours. Okay, so one is the Lakota medicine wheel, and in the center is not people, it's spirit or mystery. This information is from Stan Grof's book on spiritual emergency. He was part of that first wave of psychedelic research. He did thousands of psychedelic-assisted sessions in the 1950s and 60s. He is still alive. He is still lecturing, writing, and part of what's called the psychedelic renaissance. So he wrote this book on spiritual emergency to describe two different possible trajectories for people who are engaged in psychedelic therapy. By far the most common is this idea of spiritual emergence. Most people have an overwhelmingly positive experience. They have new insights. They have this sense of expanded consciousness, and it's a gradual, gentle, personal evolution. The other possibility, which is less common but really important to know about, is spiritual emergency. In this case, somebody has an intense experience, usually of ego dissolution, that's very jarring, and it just stays in the foreground of awareness to the point where they're having trouble just functioning in their everyday roles. So they might become obsessed with thoughts of death. They might have these new fears that weren't there before, like fear of change or fear of interacting with people. They might start to wonder that if they're losing their sanity. Okay? They might feel very, very isolated, like no one understands this experience. They can have sudden physical symptoms with no explanation. And this is often mistaken for psychosis. It looks like psychosis. But the treatment is deeper engagement in individual psychotherapy so that they can gain insight, work through some of these new perspectives that have come up, and community, community, community. More social support. Another way to think about spiritual emergency is that it is a decentralization of the self. This is a strange idea in our culture because we take for granted that humans are at the center of things. You know, we've arranged our entire world to serve the desires and needs of human beings, maybe at the expense of other species, at the expense of the environment, or we see humans as sort of being at the top of a hierarchy. So it's just important to know that Western culture is an outlier in this regard. If you look at traditional societies across the whole world, across time, they don't see it like that, right? That decentralization of the self is just part of their worldview. It's part of their cosmology, their view of the universe. So, just want to show you some visual examples of that. I'm not going to talk a lot about it. So this is the Cherokee medicine wheel, and what most of these cosmologies have in common is the idea that there's an earthly plane of existence, and there's a lower world and an upper world. Okay? So these are and I picked a few examples out of literally hundreds. This is the ancient Hebrew conception of the universe. In none of these are you going to see people. People are just, you know, they're kind of part of the flora and fauna, but they're not a big deal. This is the Norse tree of life. Again, the plants and animals, and then there's an upper world and a lower world. This is the mandala of Mount Meru in the Buddhist tradition. Different levels of being, different levels of existence. This is the Navajo cosmology. Again, you can see that there are sort of divine beings in this upper world, and then there's an earth plane, and then there's a lower world. This is one diagram of ancient Hindu cosmology. And this is ancient Greek schema of the earth and the heavens and the underworld. This is an image of the legend of Turtle Island, the Native American tradition where how humans came to be in North America. So in closing, I will say we need good medicine. We need the default mode network. We need science. We need evidence-based medicine. And we also need these technologies of the spirit. And that probably that knowledge is not going to come from Western medicine. So we are going to see some really interesting and unpredictable intersections between these two worlds as we begin to integrate psychedelic medicine into our mental health practice.